Great, I think we'll get going. So I'm Verity Algar. I'm a Senior Policy Advisor at the Department of Health and Social Care in the UK, and I am a trustee of the Healthy Heart Trust. The Healthy Heart Trust was established in 1996 as the Cardiovascular Research Trust. Our mission is to promote healthy heart living and the prevention of cardiovascular disease through education, outreach, and policy. We're the home of World Healthy Life Week, which is an international event now in its fourth year. It's about taking a holistic view of our heart health to promote a healthy life for all by focusing on the message of how keeping our heart healthy is central to overall good health. The week is held in partnership with the Fellowship of Postgraduate Medicine, and the theme this year is Health Inequalities Towards Cardiovascular Health Equity. Thank you very much for joining this webinar, which is about women's cardiovascular health. It remains an uncomfortable fact that despite many women suffering from acute coronary syndromes, being at lower risk than men, they remain undertreated. There continues to exist an unmet need to better understand and address differences in short and long-term outcomes between women and men in terms of cardiovascular disease. I'm really pleased to be joined by three experts in this field, Dr. Sanne Peters, Dr. Amy Sama, and Drew Lawrence. So a few practicalities before we kick off. Please ask questions throughout the course of the webinar using Zoom's Q&A function. We'll have the opportunity to put these questions to the panel after their presentations. Also like to encourage you to tweet about the webinar using the hashtag World Healthy Life. That's hashtag World Healthy Life. So first up, we have a presentation from Dr. Sanne Peters, who is an associate professor at the George Institute for Global Health and a senior lecturer at the Faculty of Medicine at Imperial College London. She holds a joint appointment as an associate professor at the University Medical Centre in Utrecht. Her research focuses on sex differences in the prevention, presentation, management, and outcomes of chronic disease, mainly cardiovascular disease and diabetes. Over to you.
Thanks, Verity, for that introduction. Are you seeing my slides at the moment?
Yes, we can see those slides. Brilliant.
Okay, thank you. Yes, my name is Sanne Peters. I'm an epidemiologist focusing on sex differences in cardiovascular disease. But before I start my talk, I would like you to take a few seconds to look at this painting by Rembrandt van Rijn. It's called The Anatomical Lesson, and the thing that I see here is still sort of like depicting the situation today, although with some minor improvements, namely that both the healthcare, well, the teacher being Rembrandt van Rijn himself, the students, but also the already dead patients are all men. And that's how research has looked like for many centuries. But sadly still to some extent looks like today. So I'm indeed going to talk today about sex differences in cardiovascular disease. My slides are moving, right? Yeah, okay. Right, so why is this still an issue today? Well, we are here today because women are still underrepresented in cardiovascular research, and that has a detrimental impact also on the quality of care that we currently provide to women. And on this slide, I show that the participation of women in clinical trials is not equal to the number of patients, number of female patients in the clinical setting that present with cardiovascular disease. So if the participation of women in trials would be equal to the prevalence of the disease in the population, then this so-called PPR would be 1. But as you can see, for acute coronary syndrome and for heart failure trials, women are vastly underrepresented in clinical trials. However, we know that there are important sex differences in the area of cardiovascular disease. And there was a Lancet commission on women and heart disease last year that if you haven't read it already, would really recommend you to read. Unlike the common misperception that heart disease is a man's disease, we actually know that almost the same number of women and men each year die of cardiovascular disease. And in women, it's the leading cause of death worldwide. About 1/3 of all women in the world die of some manifestation of cardiovascular disease. We also know, however, that, as I already said, cardiovascular disease among women is vastly understudied, and as a result also under-recognized, under-diagnosed, and undertreated. And as I showed on the previous slide, women are still vastly underrepresented in clinical trials in the cardiovascular domain. And now we'll move on to talking about what those sex differences in cardiovascular disease look like. And I won't focus on everything, but I'll just focus on a few highlights so you get an idea. Well, first of all, cardiovascular disease is not one disease. It's collection of various diseases in the heart and vessels, and the main subtypes of cardiovascular disease are coronary heart disease, which is essentially an infarct, also often called heart attack, or cerebrovascular disease, which is also called a stroke, which happens in the brain. We know that coronary heart disease, so a heart attack, typically happens more often in men, and it also occurs at a younger age in men as compared with women. Once a woman has a cardiovascular event, it's typically 5 to 10 years later than the average age in a man. However, the lifetime risk of cardiovascular disease is very similar between the sexes. At the end of their lives, as I said also on the previous slide, about 1/3 of all men and women have died of some kind of manifestation of cardiovascular disease. As you can see on this slide on the left-hand side, women are much more likely to develop stroke, so the disease of the brain, which tends to happen at a later age, and often also results in severe disability, and also a lot of admissions to nursing homes where the populations are predominantly female. In addition to sex differences in the presentation of cardiovascular disease, we also know that the symptom presentation can be different. However, unlike the common misperception that there are sex-specific symptoms for heart disease, it is actually slightly different. What we know that the top 3 symptoms of heart disease are the same in both women and men, and these are shortness of breath, chest pain, and discomfort typically in the left arm. And this is the same for women and for men. Women, however, also sometimes have additional symptoms of a heart attack, which are sometimes not immediately seen as heart attack symptoms. And these can include sudden dizziness, nausea, vomiting, unusual tiredness. And obviously these symptoms can be the cause of everything. And that's also the reason, well, not of everything, but a lot of other different conditions. And that can be a reason for a heart attack to be missed more commonly in women as compared with men. But the bottom line here really is that the misperception that heart disease symptoms in women and men are different, that really needs to be challenged, because it is not true. The main symptoms of heart disease are simply the same in women as in men. Women, however, often present also with additional symptoms. Then on to the risk factors, which has been actually my main area of research for the past decades. Well, risk factors for cardiovascular disease in women can, to some extent, be categorized in three different categories. We, of course, have the sex-specific risk factors related to reproductive factors, pregnancy, hypertensive disorders of pregnancy, etc. I'm not going to talk about that too much today. There are, of course, also unrecognized, or at least less commonly considered risk factors of heart disease that occur more often in women as compared with men. And you can, for example, think about abuse, intimate partner violence, but also, for example, socioeconomic deprivation or poor health literacy. I'm also not going to talk about that today. I'm going to talk about the well-established risk factors that happen and are present in both women and men. However, the impact of these risk factors can still be different between the sexes, and I'll focus on that. Both for the sake of time, but also because these risk factors, so the risk factors at the bottom, like hypertension, so high blood pressure, dyslipidemia, so high cholesterol, diabetes, obesity, unhealthy diet, sedentary lifestyle, and tobacco use. These are the main risk factors for heart disease, irrespective of sex. But like I said, the impact can be different between the sexes, and that has been my area of research for the past decades. So when I say the impact can be different between the sexes, I mean that the greater additional risks of heart disease and stroke associated with some of these risk factors can be different between the sexes, and that is shown on this slide. We've gone through the literature and also did our own research to look at the associations between the most important risk factors for heart disease, like I said, blood pressure, smoking, diabetes, and we looked at the risk of heart disease associated with these risk factors. And as you can see in the columns, each of these risk factors are associated with a substantially increased risk of heart disease, irrespective of sex. However, the magnitude of that additional risk is different for some of the risk factors. And the main risk factors where we see these sex differences are smoking. Women smoking increases the risk of a heart attack by 25% more as compared with a man who smokes. And for diabetes, we also see substantial sex differences. The risk of heart disease associated with diabetes is 44% greater in women as compared with men. And we see the same for stroke, but then in slightly lower magnitudes. It's important when looking at these sex differences in relative risks to also to still consider that the absolute risk of heart disease for women, as I also said before, at a given age is lower as compared with a man. So the lifetime risks are similar, but the age standardized risks for women are lower as compared with men up until old age. So when I'm talking about sex differences in risk factor associations, I mean that the increase in risk associated with that risk factor is bigger in women as compared with men. However, also, for example, in the presence of diabetes, where, as I showed in the previous slides, we show a bigger risk increase in women as compared with men, the absolute risk of heart disease is still greater in men. So it's important to keep this difference between absolute and relative risks in mind when talking about sex differences in risk factors. Okay, for the remainder of my presentation, I will briefly touch upon the potential reasons for why these sex differences might exist. First of all, you might think that it might be an artifact because, like I showed on the previous slide, we're looking at relative risks, and it's easier to move from an absolute risk of from 1 to 2 than from 10 to 20. That's a mathematical fact. However, we do not see sex differences for all of the risk factors. So if all the sex differences that we see in risk factor associations would be artifactual, then we would have to see risk factor association differences for all the risk factors, and we do not do that. We do not see that. So that's why differences in access and biological explanations are the more likely explanations. When I talk about sex differences in access to care as explanation for the sex differences, for example, in the association between diabetes and heart disease, I always show this slide where I show that that women and men actually with diabetes in the UK are not receiving in the guidelines recommended care processes, not only for the control of risk factors, but also for the care processes that are recommended by the guidelines. And after multivariable adjustment, we indeed see that women are 15% less likely to complete all care processes as compared with men. And this is for the diabetes population. So it may be, if this is only restricted to people with diabetes, that this underpins the sex differences that we observe. However, sex differences in care are not restricted to people with diabetes. We also see them, for example, in this population where we looked at people who had survived a heart attack, and we looked at whether these people received the guideline recommended high intensity statins that are, as I said, recommended in the clinical guidelines. And what you see on the slide is that for different groups of statin users at baseline, and women are with the dashed lines and men are with the solid lines, that women are 10% less likely to receive the guideline recommended high intensity statin dosage as compared with men. So this is irrespective of diabetes. This is something that happens in a heart disease, in a heart attack population. And we see that also here, again, the slide where we looked at in a slightly different population, again, the secondary prevention of heart disease. And we found that women were not only less likely than men to achieve all treatment targets, so targets for blood pressure, cholesterol, and diabetes control, but also they were less likely to meet some of the lifestyle targets. And the only area where women did better was in the fact that they were more likely to be a non-smoker, but it is also because this study was done in an Asian population where women are less likely to smoke. But across the board, women are less likely to achieve all treatment targets, and also less likely, for example, to be referred to cardiac rehabilitation. Women typically manage their blood pressure better, and that's an area of further research, and of course something to be more optimistic about. So then, as a final part, the biological explanation. Diabetes is not a disease that happens over a night time. It's a continuous process, and it's often measured also by levels of HbA1c. So a level of diabetes, the diagnosis of diabetes is typically defined as an HbA1c level of 6.5% or higher. We had access to data from the UK Biobank, a large cohort study in the UK, including 500,000 men and women in the general population. And we looked at the association between HbA1c and the risk of myocardial infarction. And what we found actually was quite surprising, because we found that each unit increase in HbA1c, independent of whether people had diabetes or not, was associated with an 18% greater risk of myocardial infarction. And this was seen both in women and men. So in a few slides back, I showed that diabetes was associated with a greater excess risk of heart disease in women as compared with men. But we don't see that back when we actually look at diabetes as a continuous process measured by HbA1c. So this actually questions whether diabetes by itself is the cause of the sex difference, or whether something else is happening. And we think at present that the explanation might be in the sex differences in body composition and body size, because as you all might know, women typically are more pear-shaped, share more fat, store more fat in the abdominal, less fat in the abdominal regions, more fat subcutaneously. And this might be related to a lower risk of diabetes initially, but once they develop diabetes, they might be worse off as compared with men. On the left-hand side, I will finish off.
Brilliant, thank you.
Finish off. So the bottom line is that the process of diabetes might be different in women as compared with men, which might underpin the risk, the sex differences in the risk. So my final slide is that there are important differences between the sexes. and that we need to make sure that we include enough women in studies, and subsequently that we can disaggregate data by sex, so that we can inform policy subsequently. Thank you very much for your attention.
Brilliant. Thank you very much, Sanne. So this is just a reminder that continue to feed the Q&A with any questions that you have, and we can pick those up in the questions section at the end. It's now my pleasure to introduce Dr. Amy Salma, who is the co-director of the Women's Heart Health Programme and Cardiovascular Disease and Pregnancy Programmes at Massachusetts General Hospital in Boston. She's also an assistant professor at Harvard Medical School. Her research focuses on integrating digital health strategies into postpartum care to improve maternal outcomes and reduce disparities. Great. Take it away, Amy.
Wonderful. Thank you so much for having me, and I congratulate the Healthy Heart Trust for highlighting this very important topic. You go to the next slide. Some of what I'll be talking about, you can go to the next slide as well. Some of what I'll be talking about today overlaps with something that some of the data that we just heard, but bears repeating. So I just wanted to emphasize again that cardiovascular disease is the leading cause of death among both sexes. So these are data from the United States, in which you can see initially that with advances in cardiovascular disease, really men were the first to see a significant improvement in the risk of mortality due to cardiovascular disease. And really, it was just more recently with increased awareness of the risks of cardiovascular disease in women that we've now seen women enjoy that same improvement in cardiovascular health. But there's certainly much more to be done, as I'm going to be showing you next. You could go to the next slide. This is a study in which we looked at patients after what we call a non-ST segment elevation acute coronary syndrome. So that's a specific type of heart attack. And we looked at the risk of all-cause mortality in women as compared with men. And as you can see on the panel to the left, consistently, women remain at high risk or higher risk for all-cause mortality as compared with men after an acute coronary syndrome. And then, as you can see on the panel to the right, you can see at the unadjusted risk for both major adverse cardiovascular events or MACE and all-cause mortality, again, was higher in women as compared to men. But actually, when you looked at the adjusted risk, so now adjusting for baseline differences in baseline comorbidities, as Dr. Peters highlighted, and then also looking at adjustment after accounting for differences in treatment that women versus men received, that actually you see that maybe after this adjustment, women could have been in a better spot with respect to major adverse cardiovascular events and all-cause mortality. And I really highlight these data just to show that there is a lot that we can do and that is within our reach to improve cardiovascular health in women. The next slide, please. I also want to highlight that young women are particularly high-risk patients. So we often think of cardiovascular disease as being a disease of older people, but this is a recent study that came out that looked at all-cause hospitalizations in the year following an acute myocardial infarction or heart attack, and actually found that when you looked at younger patients, women were actually at higher risk for hospitalization as compared with men. So these are really a very high-risk group and one that we need to study and understand how to care for even better. So next slide, please. Unfortunately, so this is data from the American Heart Association, in which they actually look at awareness of cardiovascular disease in the United States among both men and women. And they ask patients, what is the leading cause of mortality? And so you can see the responses here. And even though, as I mentioned, cardiovascular disease is the leading cause of death among both sexes, you can see there's a declining awareness of that over the past decade among women. And so this is really troubling that we know that women are at high risk for adverse events, particularly after a myocardial infarction, but may actually underappreciate their risk for cardiovascular disease. So this is something that really requires more awareness. Next slide, please. This was already mentioned by Dr. Peters, but I think that there has been this conception that there are differences in the symptoms that men and women present with at the time of an acute myocardial infarction. But in fact, 87% of women and 90% of men, so not a significant difference there, present with chest pain. The difference that has been highlighted by a couple studies now is that women may present with a greater number of additional non-chest pain symptoms. And so a way to think about this is that they actually maybe present with a greater symptom complexity, even in the presence of chest pain. And maybe this, requires a heightened awareness because, as you can see here in this table, these are data from the Virgo study. When you look at the differences between men and women, you see that there are a higher proportion of women, 53% here, in which the provider taking care of them did not think that their symptoms were due to cardiovascular disease. And so this really requires a heightened awareness among the part of medical professionals in sort of understanding how to take a chest pain history and understand how to tease apart patients presenting with potential acute coronary syndromes. Next slide, please. Going back to data that I presented earlier regarding adverse outcomes after non-ST elevation acute myocardial infarctions, these data are consistent with that presented by Dr. Peters, but we know that women tend to be older at the time of a myocardial infarction or a heart attack, and then also tend to have a higher burden of comorbidities, particularly high blood pressure, high cholesterol, diabetes, and heart failure, and also renal dysfunction. And so they can, in some ways, have a greater burden of disease complexity at the time of their initial presentation. But then concomitantly at the bottom, you can see here that they are also at risk for being undertreated with guideline recommended therapies. And so they are less likely to actually undergo coronary angiography during their index presentation, and less likely to receive or be discharged on guideline-directed medical therapy. So this is a really concerning trend, and one that we really need to be thinking about collectively how to improve. I have on the left here also just a summary of data from another study looking at patients presenting with ST elevation myocardial infarctions. So these are very readily identifiable types of heart attacks and ones that need to be treated in a very short amount of time with coronary angiography. And we see in that study that women are at risk for having longer, what we call door to balloon time. So it takes longer for them to have their artery opened up, even when they present with this very readily identifiable type of heart attack. Next slide, please. The other thing that I want to highlight is that actually cardiovascular disease takes on a greater phenotype in women as compared to men. So a lot of what we've been discussing so far has really focused on traditional obstructive atherosclerotic disease. But women are actually more likely to present with something called MNOCA, or myocardial infarction with non-obstructive coronary arteries. So what does this mean? There are a variety of causes of MNOCA. So as you can see here in the top panel in particular, a lot of patients, even when we're talking about atherosclerosis, a higher proportion of women as compared to men can present with plaque erosion or disruption as compared to the traditional plaque rupture that we often think about in terms of atherosclerotic myocardial infarctions. These are much harder to detect by traditional coronary angiography, require a higher index of suspicion, and often require some more advanced techniques to image within the vessel to detect these types of plaques. In addition, again, classes of disease that cause these myocardial infarctions without obstructive coronary disease can include having coronary embolism and also coronary spasm. And so these, again, require a higher index of suspicion for these alternate types of diseases. And in fact, I actually remember during my own residency training seeing patients that clearly had myocardial infarctions. They got just standard coronary angiography. They were not found to have obstructive disease, and sort of were told, we don't know why you had your heart attack, but we didn't find any blockages. And we now know that without having that high index of suspicion for these alternate causes, and without seeking those diagnoses and potential treatment strategies, which differ from traditional atherosclerotic disease, that these women are at high risk for returning with recurrent symptoms and have poor outcomes even a year out. So it's really important to get the diagnosis right. So moving on to the next slide, please. There are also a lot of non-atherosclerotic mechanisms of disease as well that our understanding is really still emerging. So as you can see here in the top left panel, this is a schematic of what happens in a type of myocardial infarction called spontaneous coronary artery dissection, in which there is intramural hematoma that develops in the wall of the coronary vessel, causing occlusion of the vessel. And then sometimes when this false lumen gets pressurized, there can be this tear that is seen. Again, you have to have a heightened index of suspicion for this type of myocardial infarction in order to appreciate it on coronary angiography, and it's treated very differently from traditional atherosclerotic myocardial infarctions. The other thing to be aware of here on the panel to the right, we with traditional coronary angiography are able to see really what are called the epicardial coronary vessels, but a large proportion, maybe even the majority of the blood flow to the myocardium is through the microvasculature. And we are less equipped to readily image the microvasculature, although there are advanced imaging techniques that get at this. And so women are at higher risk for having microvascular dysfunction as a cause of ischemia. And again, this really requires a heightened index of suspicion that this may be going on in patients. And then finally, I have a schematic of what's called stress cardiomyopathy or Takotsubo cardiomyopathy. Women are at higher risk for experiencing this. This is not, this presents often very much like a myocardial infarction, but it's not a true MI. It's really a reversible cardiomyopathy, often induced by extreme emotional or physical stress. And so really just having an understanding and heightened awareness of these potential non-atherosclerotic mechanisms of disease. Next slide, please. I also just want to segue to highlight that pregnancy is a very high period of risk for young patients with respect to cardiovascular disease. So consistently in the US and globally, actually cardiovascular disease is the leading cause of maternal mortality, in addition to preeclampsia or eclampsia. So not directly cardiovascular, but certainly related to high blood pressure there. And so this is really something that I've been very interested as a cardiologist in understanding. How do we improve cardiovascular risk to pregnant patients? And then you can see here that that really in the United States, the risk for maternal mortality is much higher than in other high income nations. And so this is really something that we need to be focused on in order to really reverse the disturbing trend of maternal mortality, particularly in the United States. Next slide, please. I also just wanted to highlight, these are data from the CDC in the US, that women actually remain at high risk for adverse events and cardiovascular mortality a year after delivery. So we often focus on patients with pre-existing cardiovascular disease. There are obviously a lot of resources dedicated to high-risk patients when possible at the time of delivery, but thereafter, women really are not followed as closely and often have barriers to accessing care because of childcare responsibilities. But really, a third of mortalities occur in that period of time. And so we just really have to have a heightened index of suspicion when you are seeing a patient who is pregnant or postpartum and presenting with potential cardiovascular symptoms. Next slide, please. Again, awareness is key. So I just wanted to highlight here in the red, as I mentioned, maternal mortality is actually rising in the United States. But if you advance forward for a minute, actually a high proportion, 40 to 70% of maternal mortalities, when retrospectively reviewed, are felt to actually be preventable. So in California, they've actually implemented a variety of toolkits, and with that implementation have successfully seen a decrease in maternal mortality within the state. And so these are really areas that we should be focusing on to think about how we can actually improve maternal mortality in the US and globally. Next slide, please. You can advance forward again. Wonderful. So Dr. Peters very beautifully delved into sex differences with respect to traditional risk factors, but I want to highlight as well that there are emerging risk factors that we now know influence the risk for cardiovascular disease that also have sex differences. So in particular, we know that adverse pregnancy outcomes, early menopause, depression, anxiety, and autoimmune disease, which have a higher prevalence among women, actually are also important cardiovascular disease risk factors. And so again, these are risk factors that we really need to be thinking about how to help patients with in order to reduce their cardiovascular risk. Next slide, please. I just wanted to highlight in terms of adverse pregnancy outcomes, that this is some work by one of my colleagues looking at the risk for cardiovascular disease after hypertensive disorders of pregnancy. So it's easy to think that these are that hypertensive disorder of pregnancy stays with the pregnancy, but in fact, we see that as compared to women who don't experience a hypertensive disorder of pregnancy, those who do are at higher risk for later life coronary disease, heart failure, and valvular dysfunction. And this is largely, but not completely, mediated through the development of chronic hypertension. And so overall, we're not really conceptualizing hypertensive disorders of pregnancy as identifying patients at risk for accelerated cardiovascular aging. Next slide, please. So I just wanted to, again, highlight, this is what Dr. Peters has also highlighted. This is called the American Heart Association Life Simple 8. And these are, again, the major risk factors for traditional atherosclerotic disease that we can all be aware of and that we can all strive to modify in ourselves and in our patients. Next slide, please.
I'm just going to have to ask you to wrap up in the next few seconds.
Yes.
Thanks.
Absolutely. And then again, this is highlighting the need to really include more women in cardiovascular studies. And the graphic to the right, you can see really tackling this problem is really multifactorial and requires a lot of awareness and dedicated effort. And with that, I thank you for your attention, and I'm really pleased to be part of this.
Thanks very much. There was some really sobering truth in there. That was really, really interesting. This is just a reminder to keep posting questions in the Q&A function. We are now going to hear from Drew Lawrence, who is a senior features writer for The Guardian US, based in Atlanta. And Drew covered the death of US sprint champion Tori Bowie earlier this year in an article called How Tori Bowie's Death Highlighted a Devastating Reality for Black Women. Over to you, Drew.
Thanks. Yeah, that was probably one of the sadder stories I've covered over in my career, because Tori was so special. Just a generational talent, a former world's fastest woman, a style icon. She was famous for wearing a colorful headscarf during her meets. So she was always very easy to pick out, even before she crossed the finish line first. But she was not an athlete who was sort of destined for a career in sprinting. She started out as a basketball player and a long jumper, and eventually was steered into sprinting. And within 6 years was winning professional meets against Allison Felix and the like, and made her biggest splash in 2016 at the Rio Games, medaling in every event that she competed in, and most memorably rallying the U.S. to an upset in the 4x100 final. And that was like a really special moment, made more special by the fact that she had never raced in a 4x100 before, or done any kind of like relay racing before. And for those of you who cover or who follow track, you know that's a pretty tough thing to do. Never thought that, 7 years later, we would be talking about her as the poster child for maternal mortality. But after some months of her not, really appearing in meets and sort of warm-up meets to the Olympics, she was found dead in her home, and the details were especially harrowing, and not least the fact that she was 8 months pregnant and had actually delivered her child before she was found. And the autopsy report also found that she was like 26 pounds under her competition weight, which was even more jarring. And so this really shone an intense light on the maternal mortality crisis here in the United States, especially when more information started to come out about her cause of death, and we started hearing familiar symptoms like or consequences like eclampsia, respiratory distress, and high blood pressure. And all of those things made so much worse by her own history of bipolar disorder, and by sort of a cultural suspicion of institutionalized medicine that's sort of based in the fundaments of gynecology, which were staked in experiments that were conducted on enslaved women, at least here in the U.S. And it's only grown from there. The Tuskegee experiment. And there was all of these reasons for Black Americans in particular to carry suspicions about their medical care, and also plenty of anecdotal and legal cases that make the point about how they're not being listened to when they express concerns about their medical care. What I was shocked to learn when I, in the process of doing this story, was that, not very long before Tori's death, there was a CDC analysis of the maternal mortality problem that showed a 40% year-on-year spike in deaths from 2020 to 2021, and that that Black women in particular in the U.S. were 3 times more likely to die from maternal mortality than other women. And this is, of course, this isn't like a problem that's unique to the United States. We're just one of a handful of countries outside of the Americas that actually tracks data or catalogs data by race. But the real heartbreaking number was that 84% of these deaths are totally preventable. And you just think about Tori and her family and what she left behind, and the fact that women from Beyonce to Serena Williams have been sounding the alarm about this crisis for years, and it's not until the current administration and the vice president in particular that this medical crisis is getting is sort of being more scrutinized from the executive levels of federal government. And sort of another thing that made this story so urgent is that with her death, Tori became the third woman on her 4x team to experience some sort of dire pregnancy. And yeah, soon after she died, the other two teammates, in particular Alice and Felix, had been very open about her delivery struggles, her, just even before that, being a competing, trying to continue her competitive career while also starting a family. And so this is a particularly acute issue in the track and field community. But again, I feel like people didn't really see the irony of that at the time, because Tori would seem like the last woman on Earth who would have problems conceiving. She was in the 0.5% of athletes in the world in perfect shape, and yet she's not with us now. So yeah, I was also moved to do that story because my own personal experience. I have two kids. Those labors were not easy, and a lot of the same sort of like headwinds that these women faced were very familiar to my family. And so yeah, I really hope that her death can bring about some meaningful change. And I know her track and field teammates are trying to affect that as we speak. But yeah, so I'm hoping that there's some people in this webinar who are full of solutions so that we can avoid deaths like this in the future. And yeah, that's it from me.
Brilliant. Thanks very much, Drew. It was great to hear such a moving tribute to Tori, and great to focus on a personal story and the policy context there. We can now move to questions to the panel. I have a question, and I think this is directed at all three of you. What are the most effective ways that you've seen of addressing the blind spots around women's cardiovascular health? That you've seen in your personal and professional lives. And I'm happy for anyone to come in first.
Well, I'm happy to give my perspective to start. So I'm really fortunate to work at an institution that recognizes the need for a dedicated women's heart health program. And so, I'm really fortunate to be part of that program. And in that program as well, we have a dedicated cardiovascular disease and pregnancy program as well. And we have teams of people that are dedicated to this issue, both in terms of providing clinical care in a multidisciplinary fashion. So cardiologists, and maternal fetal medicine specialists. We also have therapists. And so really approach this from a multidisciplinary facet. And so I think just having teams of people that are really dedicated and aware of this issue are really important. And in addition, we are really dedicated on the research aspect in terms of moving the needle forward. And I think that is really something that I would like to see, change in the future. So the majority of the data that we have with respect to cardiovascular disease come from predominantly male and white populations. And really, we won't understand the complexity of cardiovascular disease, nor will we understand how best to deliver healthcare to a whole diversity of patients and communities, unless we really are intentional about studying that and understanding what our very diverse patient populations need.
Great, thank you. Drew or Sanne, do you have anything to add?
Oh, I was going to say, just in my travels as a sports writer, I've seen a lot more attention paid to biometric data collection, and I know that teams are much more interested in sort of a lot of the trends that are happening below the surface. And and then also, we had a pretty seismic event in the NFL last year with a player from the Buffalo Bills having having a cardiac event in the middle of a game, and being lucky to survive it because of the fast actions of the medical response team, both on site at the stadium and at the hospital. And I know that was a real wake-up call for that professional league about how it about sort of digging in a little bit deeper into their players' health profiles to sort of understand the risk factors and maybe mitigate where they can to prevent events like that from happening in the future.
Yeah, maybe some other thoughts on that. I think we've come a long way, and we've certainly made massive steps. I think when it comes to increasing the awareness of women and heart disease, but we're still absolutely not there yet. Not only in the cardiovascular field, because I think the cardiovascular field is really ahead of all the other medical disciplines when it comes to awareness of this really important topic. And secondly, women, as Drew and Amy also mentioned, are, of course, it's 50%, 51% of the population, but there's lots of diversity amongst women, but also amongst men, and that's something we cannot, we do not, that's something that's in the data, but there's more to the data than just splitting the data by some demographic characteristics. So I think this holistic approach to heart disease, and to also consider the diversity among women and among men and among everything in between, is really critical to make further progress. And I think I'm happy to see that like I said, there's increasing recognition among researchers, among policymakers. For example, funders now require researchers to look at sex and gender differences in their research. Not all funders, but there's quite a number of funders that do that now. So yeah, like I said, there's progress, but still also a long way to go.
Brilliant, thank you very much. We've got a question that's come in the chat from Maya Moda Patel, who asks, how are healthcare systems and communities supporting women from ethnically diverse backgrounds and marginalized communities who are pregnant and, because of their ethnicity, genetically more likely to develop cardiovascular disease? So I think that's focused on pregnant women from ethnically diverse backgrounds and how we can support them.
That's a
Amy, do you want to kick off? Yeah.
Yeah, I'm happy to give a brief response to that. So that is just a very complex question, and just highlights really, I think, the one of the major issues of maternal mortality in the United States is that the largest burden of that mortality is on Black women and patients from marginalized communities. I think that the underlying causes are really multifactorial. So we do know that there is a higher burden of pre-existing cardiovascular risk factors among those patients. In particular, it's, there are data out there, for example, that patients living in more rural settings as compared to urban settings are at higher risk for having chronic hypertension in their reproductive years, for example. And so there is a higher burden of disease among patients with potentially less access to routine healthcare. Another issue that I've been very concerned about is the maternal healthcare deserts within the United States, where there's actually no available maternity care within reasonable distances for patients. So then really they're quite limited in terms of ability to just access routine maternal care, and then certainly would be at, have a hard time accessing care in the context of a complication. So that is a really disturbing and concerning issue as well that I see emerging just purely from a healthcare standpoint there. And then as I mentioned, we know that postpartum patients are at incredibly high risk. Still, a year out after their delivery, women are at high risk for adverse outcomes, and the highest burden of those adverse outcomes are with respect to cardiovascular disease. So oftentimes patients deliver, they leave the hospital, we think everything is okay, and then something tragic happens. For example, we hear a lot of patients that unfortunately suffer complications at home and don't even make it to a medical setting. And so I think that we really need to have heightened awareness that patients that may have even greater burdens with respect to accessing healthcare in the postpartum period, maybe even because of negative experiences during their healthcare interactions during their pregnancy, but also because they have financial burdens, new childcare responsibilities. We're also aware that there's a high burden of mental health, issues that arise in the postpartum period can all limit access to healthcare. And so really just, I think, being innovative in how we conduct research and how we think about healthcare, particularly around pregnancy in the postpartum period. There's been some interest in using digital interventions and home monitoring to try and bring some of that care to the home, and some very initial data suggesting that there could be an opportunity to reduce disparities in that context. But really, a lot of work needs to be done because we don't understand how to really reduce the equity, or improve equity, especially within the United States.
Yeah, one of the athletes that I spoke to for my story, Sanne Peters, who is also a decorated track and field star whose career briefly overlapped with Tori's, is really interesting in finding a digital intervention solution that she feels like might sort of be that first step into getting them back into a doctor's care or medical environment, because she felt like, if Tori had had an app in her time, before her time of need, who knows what intervention she could have gotten that would have kept her around. But again, she was such a special case, not just, as I mentioned before, with her mental health history, and like you said, Dr. Sarma, just like coming from small town Mississippi, where she's not as quick to sort of or used to not having access to that kind of stuff, but also she was adopted, so there's a family history there that's a bit of a mystery. So yeah, I think a digital intervention would be a good first step to sort of untangling that whole map.
Great, thank you. We've got one more question from Professor Albert Ferro, who is the chair of the trust. Are there any data on cardiovascular disease in transgender people, male to female or female to male, and how this might be different or not?
Yes, there are. There are data, and there are also differences in the sense that transgender people, especially trans women, irrespective of whether they've been using hormones or not, are at a higher risk of cardiac disease as compared with cis women. So yeah, the data are there, and of course, from a research perspective, it's super interesting population to look at, because you are in a way able to separate the genetic effects from other effects. But from a healthcare perspective, it's clear that this transgender population is of course a growing population, but also a vulnerable population, also because of the stigma and the stress. This population has more so than the cisgender population. So yeah, there are data out there, but it's a relatively small population. From a research perspective, it's relatively difficult to research, and of course that's even without considering the stigma and the stress that's really is really high in this population. But the data that are out there suggest that the heart disease rates are higher, and it's not entirely clear yet whether it's due to the hormone therapy being prescribed, or whether it's also because of other factors. But maybe Amy, I see you nodding, so maybe you have some clinical experience with that.
Thank you so much. That's a really fantastic question, because this is something that is really extremely understudied. Cardiovascular studies to date have not captured those data, so it's not something that has been really a focus until really recently, that we've appreciated really increased cardiovascular risk, and now it's really time to be intentional about studying it and improving healthcare for transgender people who we know are at high risk. And so thank you for raising that point. I think, awareness is the first step, and that's something that definitely we need to be better about, in both in clinical care and in research.
Brilliant. Thank you very much for your answers there to our three panelists. I see that the clock has tripped over 5 p.m. So I think we'll draw things to a close there. Thank you to all our audience members for joining and asking questions. And I'd like to offer my really warm thanks to Sanne, Amy and Drew for participating in the webinar and sharing their expertise in such an engaging way. I think for me, it was great to hear from like the personal, medical and policy perspectives. I think we did a really good job of covering those three off. This is just a reminder that recordings from World Healthy Life Week will be made available on the Trust's YouTube channel. So please share these recordings with your networks when they go live. Yeah, thanks very, very, very much for joining and participating.